Welcome to this explainer. Before we begin, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Today, we're taking a really fascinating look at the massive, algorithmic financial engine that runs quietly behind the scenes of literally every single hospital stay. You see, when a patient is admitted, treated, and finally discharged, it's not just a clinical process happening. There is a highly complex, completely data-driven revenue cycle unfolding right alongside it. So we're going to decode exactly how specific clinical words translate into actual hospital dollars.
Okay, let's dive into this. Here's our roadmap for the explainer today. 1. The revenue cycle engine. 2. Decoding IPDRG architecture. 3. The power of CC/MCCs. 4. Present on admission rules. 5. ICD-10 PCS procedures. And finally, 6. Clinical documentation integrity.
Now, you might be wondering, why does this level of detail matter so much? Well, take a look at this number, $2,300. In the highly regimented world of inpatient coding, a single missed word in a patient's medical chart can cost a hospital exactly this amount in lost revenue for just one single patient. For example, if a coder misses documenting a secondary condition, like chronic obstructive pulmonary disease or COPD, alongside a pneumonia admission, the expected reimbursement for that hospital instantly drops from $8,500 all the way down to $6,200. Every word has an exact financial weight.
Section 1. The revenue cycle engine. Let's start by contextualizing where these financial decisions are actually made by looking at the broader ecosystem of hospital claims.
Every single inpatient claim follows a rigorous chronological journey. It all starts at patient admission, where demographics and insurance are captured. Next up is care delivery. Here, doctors and nurses document every test and treatment in the electronic health record. And crucially, this is where clinical documentation integrity, or CDI, teams review those notes in real time. Then comes discharge, followed immediately by the coding and DRG grouping phase. This right here is the magic moment. It's where medical coders translate those clinical notes into alphanumeric codes, and the software calculates the exact payment group. Finally, the claim moves to billing and payment, where the hospital submits all that final data to the payer for reimbursement.
The absolute heartbeat of this entire process is the MS-DRG, or Medicare Severity Diagnosis Related Group. Now, this is a vital core concept to grasp. Under the inpatient Prospective payment system, hospitals are not paid fee-for-service, meaning they are not paid individually for every single Band-Aid, every aspirin, or every minute of nursing time. Instead, they get a fixed, predetermined amount based on a clinical grouping of care. If a hospital treats a patient for less than that DRG payment, they get to keep the difference. But if the care costs more, the hospital just has to absorb that loss.
Section 2. Decoding MS-DRG architecture. So let's pop the hood and shift our focus to the actual mechanics of this software engine and exactly what data it needs to work.
So the crucial point here is understanding the stark difference between why a patient walked in the door and what they were actually treated for. The primary reason for admission might just be severe chest pain. But guess what? The MS-DRG logic doesn't care about that initial symptom. It cares about the principal diagnosis, the condition established after study to be chiefly responsible for the admission. So in this case, an acute myocardial infarction. This principal diagnosis is what drives the entire DRG assignment from the very start.
This flowchart essentially shows you the brain of the whole operation, the MS-DRG grouper logic engine. The system takes key inputs, that principal diagnosis we just talked about, any secondary diagnoses, procedures, and demographics like age and discharge status. First, the principal diagnosis filters the case into one of 25 major diagnostic categories, or MDCs, based on body systems. Think something like the circulatory system. Then, the engine checks for major operating room procedures. If there's a surgery, the case goes down the surgical path. If not, it takes the medical path. Finally, it calculates the severity to determine the exact final payout.
Section 3. The power of CC/MCCs. That severity calculation introduces us to the intense financial and clinical weight of complications and comorbidities, which we call CCs and MCCs.
The MS-DRG system is actually built on a triplet structure. Let's look at how this impacts the relative weight, because that number directly multiplies the hospital's base payment rate. If a patient is admitted for pneumonia, they land in a base tier. But let's say they also have a secondary diagnosis that qualifies as a CC, like diabetes with complications, that instantly bumps the DRG up to a mid-range payment. Now, if they have an MCC, a major complication like septic shock or acute kidney failure, it pushes the entire case into the highest possible payment tier. The system does this to recognize the massive amount of clinical resources required to keep that highly complex patient alive.
Because of these distinct weight tiers, precise clinical terminology is literally the lifeblood of the IPDRG system. It's a classic case of garbage in, garbage out. If a physician simply writes heart failure in the chart, the coding software just defaults to a lower-paying DRG. Why? Because it lacks specificity. But if that same physician writes acute on chronic systolic heart failure, that highly specific terminology is recognized as a major complication. It instantly captures the true severity of the patient's illness and secures the appropriate revenue for the hospital. Vagueness is basically a massive, invisible revenue leak.
Section 4. Present on admission rules. Now let's see how all of this builds into the critical timeline rules that dictate whether a complication actually counts for payment.
Imagine this quick mini-narrative for a second. A patient is admitted on day 1 for a severe infection. On day 2, they get standard care. But on day 3, while just resting in bed, they develop a deep vein thrombosis, a very serious blood clot. By day 4, they are treated and discharged. Now that blood clot is undeniably a major complication. But because it happened after the patient arrived at the hospital, it triggers a completely different set of rules. Now, what's really interesting about this slide is how the present on admission, or POA, indicator values work. Simply put, Medicare penalizes hospitals for conditions that occur on their watch. Every single diagnosis code has to carry a POA indicator. Y means yes, it was present when they walked through the front door. But a flag of N means the condition was not present on admission, it is a hospital-acquired condition. So in our previous example, even though that deep vein thrombosis is a major complication, because it gets an N flag, Medicare will completely strip away the extra payment weight for it. The hospital just has to absorb the cost of treating the complication they allowed to happen.
Section 5, ICD-10 PCS procedures. All right, so far we've only talked about diagnoses. Let's transition over to the surgical and procedural side of the coding engine. This uses entirely different logic under the ICD-10 PCS system.
And this brilliantly illustrates the sheer architectural beauty of the PCS coding system. Unlike diagnosis codes where you essentially just look up a disease in a big index, PCS codes are literally built from scratch using a rigid 7-character structure. Character 1 identifies the section, Character 2 is the body system, Character 3 is the specific root operation, like an excision or a dilation. By the time you get all the way to Character 7, you've built a highly specific alphanumeric code that tells the exact story of what happened in that surgery.
Now, because of this building block method, surgical documentation has to be flawless. Missing just one tiny detail can halt the entire billing process dead in its tracks. For instance, if a surgeon forgets to document whether a hip replacement was on the left or right side, the laterality, the coder literally cannot complete that 7-character code. They have to pause everything and query the doctor, which delays the claim. Similarly, vague root operations, like confusing an excision, which removes some of a body part, with a resection, which removes all of it, will completely alter the final DRG assignment.
Section 6. Clinical documentation integrity. With so much money and accuracy riding on exact phrasing, hospitals just can't afford to leave it to chance. That brings us to our final section, the vital human quality control checkpoint in this highly automated process. CDI specialists are typically experienced nurses or coders, and they act as real-time translators between clinical language and coding logic. They review charts concurrently, meaning while the patient is still sitting in the hospital bed. If they seek clinical indicators for a severe condition, like maybe some really abnormal lab results, but the doctor hasn't explicitly written the actual diagnosis in the chart, the CDI specialist steps in. They query the doctor to clarify their documentation. This ensures the final DRG actually reflects the severe complexity of the care provided. It's a process rightly called ethical optimization.
However, you can't just walk up and ask a doctor to document a higher-paying word. CDI specialists have to follow incredibly strict compliance standards governed by bodies like AHIMA and ACDIS to avoid fraudulent upcoding. Queries have to be based on actual clinical evidence in the chart, and most importantly, they must be completely non-leading. You absolutely can't ask, hey, can you document severe sepsis so we get paid more? No way. You must ask something like, given the elevated white blood count and fever, please clarify the patient's systemic infectious status.
It really is a delicate, high-stakes balance between clinical words and financial output.
Every chart tells a story, and the specificity of that story dictates the survival of the hospital's entire revenue engine. Which leaves us with a pretty fascinating question to ponder. As artificial intelligence gets better and better at reading these charts and understanding these complex DRG rules, will AI eventually replace these human CDI specialists altogether? Or will it simply become a tool that makes their ethical optimization infinitely more powerful? That is all for this explainer. Thanks for joining us as we decoded the hospital revenue engine. And remember, if you are enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal.